and welcome back to everyone who joined us last week. Today we have some great speakers that have joined us today with our Metro Center experts. My name is Helen Roldan, and I'm a researcher and outreach coordinator with the FIU Jorge M. Perez Metropolitan Center. Before we begin, I will briefly introduce today's webinar, the current and future economic and community impacts of COVID-19. Today's speakers will be discussing the health and social issues affected by COVID-19 in our community. For those that are joining us for the first time, our experts will be sharing a presentation and will then answer questions from the audience towards the end of the session. During the duration of the presentation, you will be automatically muted. If you wish to ask questions, you can type them in on the chat feature on the Zoom window. We will try to get to as many as possible during the last 20 minutes of today's webinar. The session is being recorded and we will be posting the recording on our website. We will also be emailing all participants a copy of today's presentation as well as a link to the next webinar so you can register in advance. I will now turn the mic over to our center's director, Dr. Howard Frank, who will be introducing the center and our expert researchers.
Good morning. Thank you, Helen. I'm Dr. Howard Frank, director of the Jorge M. Perez Metropolitan Center, a cornerstone of the Stephen J. Green School of International and Public Affairs at FIU. Thanks for being with us for the third installment of Beyond the Headlines, the current and future economic impact of COVID-19. Today's session focuses on community impacts of the COVID-19 outbreak, with attention to the health and economic disparities that exist for Blacks, Latinos, undocumented immigrants, and those of lower socioeconomic status. This webinar series is an integral part of Perez Center's intellectual DNA, with deep commitment to research, training, technical assistance, and outreach undertaken to improve the quality of life throughout South Florida. The Perez Metropolitan Center is a community asset dedicated to informed policy making and discourse throughout the region. Please contact us for further information on how we can put our skills and experience to use in your organizations and communities. Now, let me turn to brief biographies of our presenters, Dr. Aileen Marty, Ms. Michelle Mejia, and Dr. Ned Murray. Dr. Aileen Marty is a professor at FIU's Wertheim College of Medicine, specializing in infectious disease and travel medicine. Dr. Marty is a 25-year Navy veteran with 44 years of teaching and research. Professor Marty has been an innovator in the practice of medicine, identifying new diagnostic techniques with an emphasis on preventive medicine and cost containment. Dr. Marty has over 100 peer-reviewed publications and has extensive experience with outbreaks including Ebola, Zika, and the current COVID-19 pandemic. Ms. Michelle Mejia is Assistant Vice President of West Kendall Baptist Hospital, where she spearheads Healthy West Kendall, a community-wide movement working to transform the neighborhood by using multidimensional interventions that assess and address the many social determinants of health. Michelle started her career at Baptist 25 years ago and has taken on many leadership roles throughout the system. In 2017, Healthy West Kendall and West Kendall Baptist Hospital were chosen as one of 5 communities nationwide to participate in Communities of Excellence 2026, a learning collaborative that uses the Baldrige framework to accelerate change. In addition to her work at Baptist, Michelle is also an adjunct faculty member at Barry University. Dr. Ned Murray is Associate Director of Research at the Perez Center. His expertise in economic development and housing is nationally recognized. Dr. Murray has authored numerous studies throughout the region and state with distinctive competence in affordable housing. He has held editorial roles with Economic Development Quarterly and the Journal of the American Planning Association. Dr. Murray is a former practicing urban planner in Massachusetts, where he earned his PhD in urban and regional planning from the University of Massachusetts at Amherst. Before we begin our formal presentation, I'd like to welcome a special guest who has a few comments, Commissioner Danielle Levine Cava of District 8 of the Board of County Commissioners, who has a few words for us. Commissioner.
Congratulations to the Metro once again for ending forces of the community and helping to get us to a good resolution. Clearly, the work that you're doing on COVID, those of us in government, and is trying to navigate a brave new world. All of you who are on this call already know the fine work that the Metropolitan Center does. Wouldn't be on the call. I do very proud to have served as a member of the advisory for this wonderful organization. I am looking forward to guide a response. My office, and we've been providing updates about the county response. We've been hosting our public affairs show. Versus doing a, please, if you are not following on Facebook or Instagram, and you can sign up for a newsletter as well. So it's Ella Levine Cava. And with that, I'm going to sit back and full information and look forward to specifically focus on government. Thank you, everyone.
Thank you, Commissioner. Ned, you have
Good morning,
one.
everybody. Glad you could join us for the third in the series of webinars on the economic and community impact of COVID. The first 2 weeks, we focused mainly on the economic impacts. With the job numbers coming out each week, the economic shock was more like lightning in terms of the number of jobs that were lost. The unemployment claims, we filed more unemployment claims in the first 2 weeks than the first 2 years of the Great Recession. Those numbers continue to climb. We'll see some new numbers next week, and we anticipate that we may be hitting the 30 million mark. But with any type of economic shock, what we find is that the community impacts, the social impacts, come a little bit later. In this case, they came a little bit more quickly than we would have anticipated, but they did come in staggering numbers in terms of the impacted communities, as Dr. Frank had mentioned at the outset, particularly lower income communities, communities of color, undocumented workers. These are all the communities that are being significantly impacted. Getting back to the actual orientation once again of the research, for those of you who have been with us for the first 3 weeks, the purpose was to really reach out and look at how the COVID-19 pandemic had been impacting obviously the economy, but more specifically the businesses, the local governments, nonprofits of South Florida. So we really zeroed in on those businesses, those that are most vulnerable. So the three features or three elements of the research consisted of the impacts on the most vulnerable industries, and of course the employment sectors. And we do have infographics on our website you can look at. We obviously have 2 prior webinars that you can go back to. Those videos are still available to look at those numbers. So now we're at that point where, like as I said, we want to focus on the community and social environmental impacts, and these have become quite severe. I'm sure many of you are following those, not only in terms of the media, but many of you have probably experienced it right in your own communities, particularly those who work in the nonprofit sector. And then, really importantly to us was to look post-COVID. A lot of these issues that we're facing, as I think all you know, especially the inequalities, the lack of a diversified economy, a lot of the other issues in terms of why so many of our communities in Miami and South Florida are so distressed. Well, these existed before COVID, and obviously COVID has torn off a big nasty bandage to show just how bad those those situations are. So we really focused over the first 2 weeks as well on what a more resilient and more equitable type of economy would look like, and planning on that right now. So we spent a lot of time on that. We'll just be spending a lot more time on it in future webinars, particularly next week when we talk about governments. So with that, we were challenged by a number of listeners and participants, and obviously people who come to us as the Metropolitan Center to look at what these numbers we're seeing in front of us right now, these takeaways in terms of rapid employment loss, the fact that most of our businesses are really, really small, they're micro businesses under 10 employees, and what this might look like, what a resilient economy would look like, what its key elements, but looking at it also from the lens of the community impacts. Now, we're very effective as are others in doing economic modeling, and Dr. Mileva in the first week shared some of those numbers with you, some of the results of the economic modeling, particularly as it related to the cruise line industry and hospitality, and those numbers obviously were quite staggering. So with that, we were asked, could we develop a social model, social impact or community impact model? So we spent some time on that, and we did come up with what we think is something that could serve as a real tool for who are those questions themselves right now is, how do we approach this? How do we deal with these community impacts, and based upon the job loss, but also the ongoing issues that they're facing, whether it be in the area of health, obviously the jobs, the loss of income, obviously other issues that are really distressing these communities. So that was the focus, was to do something that would be rapid. That's what we called the COVID-19 Community Impact Rapid Response Model. And the idea was to provide this dynamic and systematic approach for identifying the types and the levels of economic and social stress, and then to come up with actual strategies, responses that would be obviously efficient, impactful, and evaluative. So some of this feedback that we actually got from the nonprofit world, from donors, from foundations who've been in contact with, was to come up with a model that could be used and used very, very, very easily with results, hopefully, on the short term. So here's how the model actually works. The model has 4 parts to it. The first part, which we refer to as the Community Distress Index, is really a enhanced targeting tool. It's an enhanced targeting method that is able to really isolate geographically what's going on, and using a number of different indicators, many of which you would find in a social vulnerability index, or of course the social determinants of health. But it goes beyond that to become much more specific to the geography, and it also connects. It also connects us. For instance, we can look at a particular community down to the block level and know what the connection between employment loss within a specific patient at a specific income, and how that's impacting them in terms of housing distress. So there's a number of extrapolations that we can do with data to really determine what the levels of distress are within a defined sub-geography, and then delivery of an appropriate strategy. The second element, which we've done concurrent the distress analysis, would be a community resource assessment. We all know that community-based economic and social services are critical assets which need to be marshaled to confront both the short and long-term impacts of COVID-19. So what this does, the community resource assessment, is identifies location and types of services and programs available to neighborhood residents and provides a gap analysis of the type, quality, and accessibility based upon the Community Distress Index. The assessment will also examine the use of existing funding sources, which was something that some of our donors were interested in, whether it be governmental, philanthropic, charitable, those that have been allocated to community-based organizations within the community to identify potential leveraging and partnership opportunities. So with that, the combination of the Community Distress Index and the Community Resource Assessment, the model concludes with a priority needs statement that will inform the scope and the scale of the community impact rapid response strategies themselves. The third aspect of, third element of the model are the strategies themselves. The priority needs statements will provide the foundation for articulation of the rapid response strategies and the programming for these targeted populations and neighborhoods. And once again, this is enhanced targeting of these locations. The rapid response strategies will be designed to address a range of community issues, including economic relief, medical and public health services, food insufficiencies, employment, renter assistance, homeowner counseling, mental health services, home education, and a variety of other strategies to be put in place. And lastly, but certainly very importantly, the fourth element is the performance and evaluation, which we know from donors and from a number of other organizations is really critical and oftentimes lacking. So important to the viability of the model is the ability to evaluate the effectiveness of the rapid response programming. So the model includes a comprehensive performance management system for program evaluation and includes smart metrics, program monitoring, a management scorecard, and a design of effective feedback loops to listen to and engage the impacted populations, neighborhood organizations in terms of program quality, effectiveness, and accountability. And this we see as really important because I think, as many of you know, if you can design effective feedback loops, you're also building capacity. So this isn't just a one-time deal. This is building that kind of capacity in the neighborhoods to deal with these issues and these inequalities, these the levels of distress long term. I should also mention, lastly, that an important feature of the model is its ability to adapt to economic and social variations among neighborhoods to enable design of rapid response strategies and programs tailored to the most pressing needs of the target population. So the model's framework includes a wide set of variables that can be monitored and re-examined as the impacts of COVID further unfold and become better understood. So the question is, what are the community benefits from this, beyond the fact that this would obviously assist donors and obviously assist organizations and that are actually dealing with these issues? Well, one is integral to the model and the response strategies is the ability to target, marshal, and leverage community development resources. So with the ability to identify and isolate within a smaller subgeography, the model allows community-based organizations and their donors to focus on specific treatments and program responses that can be quickly delivered and be more impactful. And then lastly, by identifying and isolating community-level hotspots of opportunity and need, the community impact rapid response model can help community-based organizations better leverage partnerships and other community-based organizations and with institutions and local governments. We can answer more questions about this later. This is the rollout basically of the model. We have not applied it yet. We put all these pieces in place, input from the nonprofit sector and the donor community. They were looking for something that they could use and apply in a very short order. So with that, please get in touch with us if you want more information on this, how this model works, and we'd be to discuss that with you. Thank you very much.
Dr. Marty, you have the floor.
Thank you. Okay, let me get my slides ready here, up on the panel here, just a second. Hang on. Let's see how to do this. One more second here. Okay, let's see if we can get this up. Oops. At the top. Anybody have any questions before I start? Since it seems to be taking me a second here to get this up and running. Just a second here. All righty. And can you see my slides?
Yes. Yes.
Okay, fantastic. Okay, so let's go. Let's talk about COVID-19. I won't emphasize the economy because that's not my area, but of course, clearly having an impact on the economy, just as the economy is having an impact on health, which is always the case. So this disease is clearly a One Health disease because it impacts the economy. It is impacted by the economy. It is the social determinants of health are all involved in this disease. It is an adaptable virus. It's a virus that has a reservoir host in bats. It's a non-selective virus because there is lack of species specificity, as I'll get into. There is not a problem with vectors for this disease that we know of. And we do have an immunologically naive population. Clearly, it's having a good impact on the environment. So there's always a silver lining on everything. And of course, it impacts on mass gatherings. So it's a One Health disease. What do we see in terms of the world economic impact? Clearly, it's having an impact on the gross domestic product, as well as the Dow Jones thing. What we know about this disease is, and the global economy is that we know the global economy has become more interdependent in recent decades, and most products are produced in multiple places. And that's really led to a tremendous supply chain issue felt all over, and very much so in the healthcare industry, for all the different parts and products that we need to take care of people, including the components for certain medications that came from particular places. And more recently, everyone's been talking about the impact on crude oil. This all has a health impact, particularly on vulnerable populations that are already stressed, that are overburdened and underfunded, and particularly in communities that have all kinds of underlying conditions because of their impoverished position and lack of access to health care. So these economic consequences lead to paucity of testing, as well as disruption of healthcare in all levels. We all know that it's impacting education and certain cultural features in certain communities, and there's a variety of communities where this is noted, have close human interactions that perpetuate the spread of the virus, as well as multi-generational families, which can also make the problem greater as the more vulnerable members, the elderly members, are in close contact with people less likely to manifest disease, and so forth. Of course, there are political complications in some countries, especially certain countries that border the Caribbean right now. So what is this? It's an outbreak, it's an epidemic, and it's a pandemic. So it started as an outbreak, which is defined as an illness that emerges or is an old disease that happens in unexpectedly high numbers. That was in Wuhan and then Hubei province. As it spread to more provinces in China, it became a epidemic, and once it spread beyond China and had sustained transmission outside of China, then it was typically and classically by Epidemiology 101, a pandemic. That's the definition. WHO knows that. It didn't use that term. It didn't use that term for a very good reason. It's not its responsibility to use that term. That is not in the mandate under which WHO operates. WHO operates under the international health regulations signed by every member state, including the United States, in 2005. Under that, the responsibility of WHO is to call it a public health emergency of international concern. And we can discuss whether it should have done it 1 week earlier or not, but it did declare it a public health emergency of international concern on the 30th of January of 2020. And it took the usual outbreak investigation steps to determine what the worldwide risk was from this agent. And already, as I said, on 30 January, it called it that. So what is this virus? This virus is a member of a large order of viruses called the Nidovirales. Nido means nest. And all of these have nested genetic information, hence the name. The family that we're most interested in, of course, is the coronavirus family, which is a huge family of viruses that impacts many, many different species of animals. And in the particular genus of interest, there are 4 interesting genuses in the family coronavirus: alpha, beta, delta, gamma. It's the beta coronaviruses that are causing COVID-19. Specifically, it is a member of the subgenus Sarbecovirus, which includes SARS-1 and SARS-2, and lots of other SARS viruses that are normally present in the reservoir host, which is the bat. And mind you, not only is SARS-1 and SARS-2 in the same subgenus, they're actually the same species and differ more as a subspecies level than as a species. And that's an important fact to understand. So when studies were done of the genetic sequence of this virus, it was determined that the absolute closest that had ever been found was found in a horseshoe bat, and a particular specimen, the RATG13 specimen, which was collected from a particular Rhinophilus affinis bat in Yunnan province, which is about 1,000 miles from Hubei province, in one little cave, and that's about 97% similarity. You can see here's the SARS-CoV-2 virus and how similar it is to this Rhinophilus affinis virus. Now, these viruses bind and get into our cells using something called a spike protein, and a very particular part of the spike protein makes it so that it's kind of like, this is the spike protein is kind of like the key that has to enter through a lock. It turns out that COVID-19 is very much a One Health disease because the receptor binding domain of the spike protein binds very well to the ACE2 receptor of felines, ferrets, macaques, and chimps, as well as us. So if you just look more carefully here, here is the spike binding to the ACE2 receptor so that the virus can get inside a cell. And this kind of puts it in perspective of what we're looking at for the SARS-1 and SARS-2 virus, and we're still trying to understand exactly how it spilled over into the human population. There's a lot of work being done. We don't know exactly how that happened, although looking at that receptor binding domain and the receptor binding motif that allows it to enter the human ACE2, that is the most variable, naturally changing part of any coronavirus, and so it's very typical for that to be something that changes, and so the change is most likely a completely normal manifestation of what happened. Now, we saw the big change in the world on March 16th because that's when the rest of the world overtook China in terms of numbers of cases, and soon thereafter in numbers of death. At that time, there was 164,837 cases, and today we are at which is just over 30 days away, 2.5 million cases, more than 2.5 million cases, with 178,845 deaths. And if you look at every day, I follow the case fatality rate for what's going on, and every day the numbers look worse. So you look at what's happening in Europe today, they have 988,241 cases, with the case fatality rate today, which is higher than it was yesterday, which was higher than the day before, of 10.63. And we in the US, we're not that different. Our case fatality rate now is 5.46, which is higher than it was yesterday, which was higher than the day before. So if you look at it from these perspectives, this is not particularly good news. And I emphasize that our death that we are detecting or that we're reporting in every country is way less than what's actually going on. Part of it is some different countries' leadership issues, thinking that by hiding the truth, they're better off, but in fact, they're just blinding themselves, coupled with other issues with lack of funds, lack of equipment, and so forth, where you have under-testing and under-reporting. And of course, our baseline is actually off. So even these figures that you see here, where the New York Times yesterday estimated how many more cases were underreported by comparing the baseline from the year before to where we are now, even those are off because it's not noting that the baseline is actually lower than that right now, because we're not getting the traffic and the violent deaths that we normally get this time of year, or through 2020, through this time of year. Not to mention, no one seems to be taking into account the reality of every infectious disease outbreak like this, which is, as an outbreak becomes bigger, other diseases are not getting to hospital in time. When I did the Ebola outbreak, there were more deaths to malaria per unit time, simply because hospitals were overwhelmed with managing the Ebola cases. Same is happening here. So this is a problematic virus, in part because it is very stable in a lot of different substances outside of the body for prolonged periods of times, different locations lasting different amounts of times. And now the comparative studies have been done with SARS-1 and SARS-2, and they're very similar under experimental conditions. And so these things in respiratory secretions can last for 7 days, because respiratory secretions have the stabilizers that the virus needs to survive. Of course, you can clean it off very simply, but you do have to clean it, otherwise it will survive. It also lasts for more than 4 days in undiluted urine or feces, and that's significant as well. Very significant when you consider that many people who have recovered from this continue to shed virus, especially the ones, children and so forth, that were symptomatic for days and days after they have absolutely no symptoms as well, and it can be as much as 30 days. So washing your hands, again, become very important, especially after going to the bathroom. All right, so what do we know? We know now that the infectious dose, which is the amount that, so we usually talk about an infectious dose 50. That's when we say infectious dose, we really mean an infectious dose 50. An infectious dose 50 is that number of viral particles that when 50% of the population experience it, they end up with symptoms, right? So if you get a lower infectious dose, you're less likely to show symptoms unless you're a more susceptible individual. And vice versa with the as the infectious dose goes up. So when we talk about infectious dose, we're talking about infectious dose 50. And for SARS-1, it was about 100 to 150 plaque-forming units. But for SARS-2, we're seeing it more like 90 plaque-forming units. The serial interval is a lot lower in SARS-2 than it was in SARS-1. And that serial interval is about 4 days, maybe 4.6 days on some studies. That means that's the amount of time between somebody acquiring virus and they're having enough virus to share with somebody else. And that serial interval, not only is it shorter and therefore producing virus a lot sooner, also we know that people have 1,000-fold more virus to share in their respiratory system in SARS-2 than they did in SARS-1. So COVID-19 is producing, these people are producing a lot more virus, a lot more. And the incubation period is about 2 to 12 days, but usually 5 days, which allows for there to be virtually everybody having pre-symptomatic or asymptomatic spread of this disease. And that's, of course, part of the reason for the high generation time cases. And of course, if we did nothing, if we didn't have all these tremendous shutdowns, et cetera, our cases would soar. And because we do not have the hospital capacity, the equipment capacity, we have supply chain issues. Even if we weren't locked down, the number of deaths would rise astronomically, because you have to put this thing in perspective. If 20% of the people need to be in hospital and need to have extraordinary measures to keep them alive, that means that if we don't have those ICU beds and we don't have those ventilators and we don't have that mechanism of providing oxygen and care, but 20% would die, which would be an astronomical number of human population. So having these things are very important. Bringing that, that curve down is very important. And we've done a number of things to that effect, and let me explain why. So what we're trying to do, what would make this safe for us to open up our economy, is if we could get the reproductive number below 1. When this outbreak started, the reproductive number as it was measured in China was 3.9, so virtually 4. What is a reproductive number? That's the number of times, the number of other people per person on average that one person infects, right? So if one person has it, do they infect 2 people, 3 people, 4 people? So on average, without doing any changes, it was at almost 4. And it varies with these features, that how long somebody is infectious and shedding virus, which averages about 10 days for SARS-2. Contact rate, how many people does that infected person come in contact with? And then what's the transmission probability when they come in contact? In other words, how close were you to the infected person? Was the infected person coughing and therefore shedding lots of virus in a big way, so that the MIT study says a cough can go 27 feet? Or was the person just speaking? This asymptomatic person, were they contaminating surfaces? Did you touch those contaminated surfaces? That's transmission probability. And the last is the susceptibility probability. That's why we're talking about healthy living, because the less susceptible you are, the lower the S is. Okay, so we've gone to recognition and we changed that by a variety of means. What we didn't have, we still don't have, is a way of changing the duration of the infectious period, because we don't necessarily have good antivirals or post-exposure vaccines. What we do have is a way to decrease the opportunity for contact and the transmission probability, and these are actually interrelated things. So the limiting of the mass gathering, the limited of the time next to an infectious person, the proper hygiene of your hands. Do not touch your face until you have washed your hands. All these things, the room decontaminations, the negative pressure rooms, are very important. And another incredibly important thing is to do the contact tracing, something we're still not doing to the levels that we should, and we're not doing the contact testing, nor are we testing still every case. In fact, patients are still being turned away who have mild symptoms, and that's a problem. That's a huge problem. And then, of course, for susceptibility, as I already said, it has to do with maximizing your health. So eat well, sleep well, and exercise every day, because that makes you a less desirable host. During the Ebola outbreak, we were able to get the reproductive rate just using the beta and kappa and S features without D, because we didn't have a vaccine at the time, and we didn't have an antiviral at the time we do now. So again, if we have the reproduction number below 1, if we're definitely on the other side of the curve, then you can judiciously open up without great risk. But you have to wait until you're definitively on that other side of the curve. To remind you, when we say mild, we really mean mild and moderate, which means about half of those are actually mild. The other half are pretty darn sick. They just don't need to be in the hospital. This is kind of a pneumonia that people have. And no matter whether you present mild, moderate, severe, or critical, you can end up dead. Some people do. Although, obviously, your risk is greater if you present with severe or critical disease. And we know that there are underlying conditions that increase your risk of presenting with severe or critical disease, including your age, including, of course, cardiovascular disease, and that makes a lot of sense since the ACE2 receptor is involved with this, high blood pressure, cancers, diabetes, underlying respiratory disease, and immunocompromised to a lesser degree. What are we seeing in the US? In the US, we're noticing it's very important that you be aware that we only see fever in children in 56% of the cases. So there's, even though most cases do have fever, a very high percentage do not have fever. Same with adults. When it's not as prominent a feature as you would want, and the fever is a low-grade fever, 99.1, 99.9, very low-grade fever in a high percentage of the cases. What we do see is if we combine the three key features of fever, cough, or shortness of breath, then you can capture 93% of adults and 73% of children. Notice the shortness of breath is not a big issue for children at all. And overall, there is a higher incidence of problems, obviously, the older that you get. How do we detect it? We have a variety of ways. We have genetic ways, and we have immunologic ways to detect it. And right now, we're still going through learning phases and trying to find out the best antibody immunoassays, and a lot of controversy involving those. In terms of the genetic ways, the first really good diagnostic test was developed at Charity Hospital in Germany on the 17th of January. It's basically, these are reverse transcriptase, which is you take the RNA of the virus, you turn it into DNA, and then you amplify that, and you see these amplification curves and plot those things out. In terms of antibody tests, it's basically, the idea is you have portions of coronavirus on a well, then you put the human sera on top of it and see if any of the antibodies that are in the sera bind. So theoretically, they're binding to the COVID-19, theoretically, and then you use another antibody like anti-human antibodies. Some of the tests use chicken anti-human antibody as an example, which then has a marker that we can see, so that you can get these a control. Here, if the person has IgG, which is the kind of immunoglobulin you develop a little later on in a reaction, to seeing a particular pathogen, and IgM, which you see a little bit sooner. And if you have both, you're kind of midway through your disease. That's the theory. The problem is, what exactly are the antibodies sticking to? How good are the antigens that are presented? How unique are they to COVID-19 as opposed to, in other words, to SARS-CoV-2, as opposed to another coronavirus? And so ultimately, how was the test validated? How good is this anti-human antibody? Is it actually only binding to the human? How well do you wash off the other stuff? All these little details make a big difference, such that we're still not terribly happy with the results of the antibody tests, most of them, not all of them. Some of them are pretty good, and we still need to figure out which ones actually work well. By the way, you've probably heard of the fact that there's now a test kit that's going to come to your homes. It's not really a test kit, it's just a sampling kit, and you send it off for testing, just to be very clear on that. So what have we learned so far from several viral outbreaks, not just this one? A lot of this is information that I tried to put out there after the Ebola outbreak, and it still hasn't come into people's crystallized in leaders' heads, but it should. And that is that our social and economic inequities risk world health and world wealth. And whenever there's a deadly or dreaded disease and it hits destitute people, as this is more and more doing, it can and will spiral out of control unless the rest of us help them. Because you can see what's happening in our own country, where we are a well-developed, it's going to get worse. And that's one of the reasons that the World Health Organization declared this a public health emergency of international concern back in January 30th. Leadership matters. You can see that countries that have taken this seriously early on have a much better result. I urge you to study this, the South Korea story. South Korea faced the MERS, which is a cousin of SARS, a MERS outbreak in 2015 when someone brought it in from Arabia, and it caused a lot of deaths and a lot of problems. And at that time, they created special teams to manage the MERS outbreak. They mirrored that for this COVID-19 outbreak, where they had special teams dedicated to COVID-19, special hospitals that were exclusive to COVID-19. They partitioned their hospitals so that there were areas for respiratory patients versus the non-respiratory patients, so that they could have that separation. They did this before the patient ever got to hospital in special COVID sites, and they did the testing. They were ready with that right away, because they didn't want a repeat of what had happened to them with the 2015 MERS outbreak. So you can see that initially in March, their cases rose like nuts, but in no time at all, their cases have stabilized. They have virtually no new cases in South Korea, a democracy, I might add, because they managed this outbreak in a very rational, very scientific way. Remember also that rumors and panic always spread faster than the infectious agents, so you have to work with the media. That's one of the reasons I do that, is to try and make sure that truthful, honest information gets out there. Climate change is altering the risk of all these diseases, changing the patterns of where the bats fly, changing the patterns of where the insects are, and that's leading to emerging viruses, which are going to continue. War and conflict, as in the Ebola outbreak in the DRC, can make things a lot worse, even if you have the technology. Psychological factors that play a huge role in the success of any kind of outbreak. Not only that, psychological factors determine in many ways how our body reacts to a pathogen. So that's one of the reasons we want stress decreased if we possibly can. And so much of our medicine is a profit-driven industry, and so much of our pharmaceuticals are that way, that we do not necessarily plan and prepare for these kinds of outbreaks the way that we really should. Prevention is super important. And right now, our world is still ill-prepared, and it's demonstrably so, to deal with a severe, sustained, threatened public health emergency COVID-19 is. And remember that health problems are not just problems of the health. They are economic, they're social, they're trade, they're travel, and there are both direct and indirect consequences on the economy. So expect the unexpected, and let's move forward, and let's try and find best antivirals and best vaccines. And with that, I conclude my conversation on this.
Thank you, Dr. Marty. Michelle?
Thank you. Thank you, and good morning. And with that, I'm going to start out by hoping that everybody is well and that they continue to be well. As part of Baptist Health for so many years, I want to start out by saying that I am very proud at how the system planned, prepared, and is responding to this crisis. But today, my focus is really on Westfield Baptist, which is where I have been for the last 10 years. And right before I discuss how we are retooling and standing up a response, I want to describe the groundwork that has been put in place and is allowing us the agility to address our community's most pressing needs. And I really believe that we have a unique story to tell, so I thank you for listening. At West Kendall Baptist, we opened our doors 9 years ago, and it was in response to the community's request for better access to care. As the largest employer, we quickly realized our responsibility to help create and support a thriving community. And that's when we conceptualized and created the movement we call Healthy West Kendall, with the goal to inspire our residents to embrace health and wellness, realizing that it affects all aspects, right, that affect health. Healthy West Kendall operates under an advisory board model with diverse representation from cross-sector of leaders, and really serves as the umbrella for many of the activities. But the advisory board brings resources also to bear, along with cross-coordinating large-scale programs. So at the same time, simultaneously, we created a community business partners group. And the group is around 100 local businesses here in West Kendall that has also been coming together for years on a monthly basis to share resources, to cross-market services, share communication channels, and plan events of all sizes. This group also helps by pulling funding streams together. So these two groups, the community business partners and the advisory board, work to create a sense of place for our residents and really serves as this vehicle to lift us all up. So altogether, we have become a grassroots convener. So part of the responsibility of Healthy West Kendall has been to gain a better understanding of the community that we share and that we serve. And just to tell you a little bit about it, we service close to 360,000 residents. And that represents, West Kendall represents 13% of Miami-Dade County. We say this all the time. If we were a city, we'd be the 4th largest in Florida. We do have 6,000 businesses. We know that many of those are micro businesses. And we created this profile, a community profile, that includes the compositions of our schools, of our faith-based organizations, our parks and recreation, to better understand also who our formal and informal leaders are. And then, of course, we identified our highest areas of need, right? Our areas of poverty, where our multiple families are living together. And all of this gives a foundation to do the work that we need to do. And as Howard mentioned in the introduction, a few years ago, because of what we had been able to accomplish, we're selected to participate in a national learning collaborative. It is called Communities of Excellence, and it uses the Baldrige framework, which is a continuous improvement tool. And it is meant to elevate and improve the performance of communities. The framework is proven to work in all other industries, but not yet in a community setting. And that's what we have set out to prove, along with 14 other communities at this time. Communities of Excellence uses 4 different lenses or drivers, and those are education, economic vitality, safety, and quality of life. And the focus is really to bring the community together, to share that common path and strategy, to understand our common needs in order to align, engage our residents, and multiply our impact. So we are working on every single one of those drivers, but for purposes of today, I want to briefly talk about the economic driver. And then I'm going to drive it down to talk about the strategies, and talking about how, once again, we are retooling those. So to gain a better understanding of our economic footprint here, we did engage with FIU's Metropolitan Center to develop an economic development analysis and economic strategies that were specific to this area. That study was completed less than a year ago. In fact, it was last June. And we learned about the many strengths in West Kendall. To no surprise, once again, a community of small businesses, 85% with less than 10 employees. We learned that we're one of the state's best overall labor forces, with a high number of residents with advanced degrees. Our percent of self-employed was higher than the county. We're a community of families, 82% compared to Miami-Dade County at 68%. One of our biggest challenge has been the net outflow of close to 100,000 residents that leave every single day to go to work. This enormous mismatch between jobs and occupations. The data is showing that only 4% of residents actually work in West Kendall. And we learned that West Kendall had a regional impact with strength in the advanced industry sector and a very strong medical cluster. So some of these conditions are obviously shifting as we speak, but when we talk about the economic strategies that were outlined in this study, today they take on a whole new importance and urgency. So for example, work shifting was a strategy that was just a year ago only on paper. And all of a sudden it's been prioritized out of necessity and carried out. We're not sure how temporary that is. We hope some of it is actually going to remain. Another strategy was to implement a buy local and hire local campaign. Obviously a focus on small businesses, a leverage of the hospital and medical clusters in order to, so that funds circulate and benefit our local workers. Also the link and the need to link residents to jobs. So all of this information, it has allowed us, right, to better understand the needs, take that with the bridges that we have built, the relationships that have been created, and the trust that we've earned are allowing us to quickly accelerate these efforts. So some examples of the responses has been bringing together those community business partners, which we're doing twice a month, and we're connecting them with resources. So for example, having Brian from SBA, he's been on many of these calls, and he is providing an almost one-on-one coaching session. He's guiding our community business partners with specific needs and even helping them complete their applications. These meetings have also been listening sessions. They've been emotional support groups at times. And I don't think that that can be underscored. I mean, listening to our people right now is probably one of the most important things that we're doing. On one of the last calls, we heard from several small businesses that can no longer pay their rent. They're already being threatened with eviction. Some businesses had not seen a sale in days. And it might not seem huge, but what we heard the very next day was how the people on that call responded by going to these restaurants, by picking up food, by offering it to others. It was a display of kindness that these partners needed at that time. We have also accelerated our buy local campaign efforts. The software has been purchased, a website is being designed. The idea is that the businesses will pay a very nominal fee in order to feature their businesses, any discounts or special offers that they are having. We have also enhanced our communication. We have a Healthy Wascando newsletter that has specific and relevant information, and that is organized under our Communities of Excellence drivers. We are highlighting and promoting our small businesses as much as we can. We're sharing information internally with our Baptist Health labor force and externally. We are also sharing the resources of Baptist Health, all of the community programs that are offered. We're making sure that those are also in the hands of our community. Just last week, we actually received great news that the Health Foundation of South Florida was funding legal services of Greater Miami with Wascando Baptist on a medical legal partnership. And this aims to bring health-harming legal aid to those that need it the most. So this partnership is coming at a much needed time and will prove to be a valuable tool in our recovery efforts. And from a social and disease management perspective, we also worked with FIU and the College of Public Health just last year to better understand the prevalence of loneliness and social isolation in our service area. And what we learned was that we had around 65,000 elder adults at risk for loneliness. So shortly after the social isolation guidelines were put in place, we were able to stand up a friendship line with volunteers that are manning it in order to be able to respond to these seniors and provide that friendly voice. So in closing, we hear so many stories from a global perspective. We hear, national crisis. We hear our state's response. I think that what we've been able to do is continue to peel the onion and respond at the neighborhood level, the family level, at a place where it truly feels personal. So obviously don't have a crystal ball, and the economic toll on our families and businesses are daunting and will be daunting for years to come. But I believe that we are resilient. I believe that a stronger West Kendall is possible. And knowing that we already have a strategy in place, that we have a roadmap, will allow us to, once again, accelerate our support of this community in years to come. So with that, I send it back to you. Thank you.
Thank you. Thank you again to all of our speakers. We have a few questions from the audience. Some were sent to me directly. Michelle, what did you mean by work shifting, and why do you want some of that to remain?
So work shifting, for example, Baptist Health alone was able to shift around 8,000 people to their homes in order to work and be safe. And if we can find ways to not have just our Baptist Health folks, but people in the community to telecommute and share spaces, that will not just alleviate that outflow migration that I mentioned, but improve quality of life of our residents so that they don't have to spend hours in traffic.
Thank you. Hannah asks, is there a proposed margin of error to account for people who were not tested and contracted the virus, and for those who passed away but their case wasn't documented? For Dr. Marty.
Can you repeat the question, please?
Yes. Is there a proposed margin of error to account for people who were not tested and contracted the virus, and for those who passed away but their case was not documented?
Some of the models used do try and account for error. However, we're discovering that the model numbers used are not where they should be, and that the margin of error is greater. So we're still in the process of trying to figure out exactly where we are in terms of deaths and actual numbers of cases.
Great. Karen asks, this is for Dr. Murray, is the framework looking at a block level analysis in all of South Florida?
Yes, the model can drill down to the block group level in any location in South Florida.
And this is a follow-up question. Denny asks, can the rapid response model be used for other community impacts outside of COVID-19?
Well, yes, actually, that's why we did it. Not just the pandemic and all the community impacts that were as a result of it, but to be able to address these issues that have been in place for some time. And in the preceding webinars, we discussed building a more resilient South Florida, more resilient economy. And we're going to have to do that for the neighborhoods on out. So building that capacity, being able to look at what's going on in these communities at a sub-geographical level, and understanding what these issues are, and building that capacity is part of a post-COVID resilient economy.
Thank you. Marissa asks this question for Dr. Marty. What organization or entity is responsible for the pandemic label?
There is no organization that's responsible for that. And the reason that WHO finally decided to use the label is simply because they realized in early March that too many leaders of too many countries weren't giving this outbreak the seriousness that it deserved. And they realized that perhaps using that term would spur nations to start doing what they needed to do to get the outbreak under control, and perhaps reduce the total numbers of cases and deaths and flatten the curve. So it was not there is no organization that uses that. It's a standard term in Epidemiology 101, and it means exactly what I said it means. that an epidemic has gone beyond one country and has spread to various countries. And those of us that work in the field were ready to call it a pandemic in early February, and certainly by the time that it had that there were sustained cases in Italy, but we didn't largely, although we did it on the side, but we didn't generally because the way Hollywood has used the term, and we didn't want to incite fear because of, you know, the zombie apocalypse type of notions. And instead we wanted this to be a rational and thoughtful scientific approach. And that's really the bottom line. There is no agency that calls it a pandemic.
We have a very important question here from Mr. Andrew. Please address the issue of some public officials in South Florida aggressively pushing for reopening businesses with apparent disregard for public health. That can be for any of the speakers. Dr. Marty, do you want to address that one first?
Hit me again with it.
Please address the issue of some public officials in South Florida aggressively pushing for reopening businesses with apparent disregard for public health.
I'm not sure which public officials are aggressively pushing that. The public officials that I have worked with are studying the issue and carefully considering what slow, staggered permissions they might allow. You know, and I work with both sides of the aisle. I'm very happy to simply provide the scientific data. And, you know, it really depends on whether or not the members of our society adhere to the recommendations of staying the 6 feet apart, the not gathering in groups. CDC says 10. I would say not more. No one outside your family group should be that is not in your household should be within 6 feet of you. That's the safer way of doing things. Wearing masks when you're out and about, unless of course you're doing an aerobic activity where wearing a mask would be suffocating. These are basic things that, and the hygiene, of course, that if people were to adhere to it, truly adhere to it, we could have some things opened up. But it really, really depends on people. And right now, when I have to go out for work or other reasons, I'm still seeing people not adhering to those things, people not paying attention to these factors. And that's one of the reasons that, you know, it's going to be longer and harder for us. If we do adhere to these, the outbreak can be contained better and we can have more freedoms. But we have to have those freedoms in the context of keeping the virus, not allowing the virus to have an opportunity to jump from one host to another.
Thank you. Do any other speakers want to jump in on that? No. Okay. Ned, were you going to say something?
I said no, thank you. That's okay.
Okay. Gotti asked, can you get COVID-19 twice? For Dr. Marty.
Right. So right now we have documented individuals who have been COVID-19 positive, who have had symptoms, who have recovered, who have tested negative after recovery once, and then tested negative again 24 to 48 hours later, and then for experimental reasons been retested 1, 2, and 3 weeks out, and we have found individuals who are now again positive who had been negative. What that means, we're not sure. It could mean that they have reacquired the infection, or more likely it means that they haven't totally cleared it, that there are some immunologically privileged sites that are still able to allow that person to shed virus. And we know for a fact that in the feces, the virus continues to be shed for many, many days in many, many people, as much as 30 days after recovery. But these other tests that I was talking about is checking the nasal passageway. So we're recovering virus from the nasal passageway. So are they getting reinfected, or are they showing the virus that's already in their system? We don't know. Can people get infected from any virus? Yes, they can. There are many things that we don't develop sufficient immunity to have permanent protection from. Many viruses are that way. In fact, some of the ones that we do have permanent protection from, the reason that we seem to have permanent protection is because we actually have a hidden form of the virus that reminds our immune system about it, such as, for example, the chickenpox virus that lays dormant in certain cells, and when our immune system drops down because of stress and other reasons, can remanifest as shingles. So there are, and we know this not just for viral pathogens, but bacterial as well. This can happen as well. So we're still puzzling that out. That's really the bottom line.
Thank you. We have a question for Michelle. How else has Baptist Health responded to the crisis?
Probably the first that I can mention is the response with the telehealth platform and Care on Demand, opening that and making it accessible to our community for free, with a special section for COVID questions. So that's probably the biggest way that we have opened up access to care and avoided people from having actually to come into a hospital setting. The second, many of the hospitals are actually purchasing more food from our local farmers and serving it in our own kitchen. So I think that's a huge plus for our farmers. And the last one is the community resources, the community calendar of events that was usually not online, moved quickly to be online. And the classes, whether it's for exercise or meditation or classes specific for seniors, were quickly put online for everyone to be able to access.
Thank you. This question comes from Howard for Dr. Marty. Will this event spur more funding for public health in state and local governments?
Will what? Public health? I didn't quite hear that.
Will this event spur more funding for public health in state and local governments?
That probably depends on who our elected officials are. It certainly should. I think if anything should wake people up about the importance of having surge capability. And one of the things that is so frustrating for me about this entire outbreak is that in the 90s, I was working with the federal government to get us ready for a terrorist outbreak. And in the early 2000s, we had the national stockpile set up, and the national stockpile had products in every state. We had ventilators, we had all kinds of things in every state of the United States. We had medicines, we had PPE, we had all kinds of things. But over time, since it's kind of like a hurricane didn't happen, right? A big pandemic didn't happen that required the use of the National Strategic Stockpile. And so it dwindled down, so that a few years ago when I checked, there were only 2 locations left for the National Strategic Stockpile, one in Maryland and one in California, which made me very sad. We had teams trained and ready, and the money and the funding for those teams dwindled down. We knew that these sorts of things could happen. Pandemics happen. They're part of Mother Nature's scheme of things, if you will. And just like hurricanes are, and you have to plan and prepare for it. And you have to realize that just because you're not ready and it doesn't happen, that doesn't mean that it's not going to happen. Eventually, that lightning will strike again. And that's exactly what happened. So I certainly hope that there will be an awareness that we need to have teams ready, hospitals ready, equipment ready. But it really depends on the wisdom of those that we elect.
Thank you for that. We have time for a few more questions. Armando asks, are there environmental analyses as opposed to clinical for those that conduct environmental cleanups? And if so, are there threshold values of viral concentration indicating sanitized surface acceptable levels?
So John Ledniski, a good friend of mine at University of Florida, does exactly that kind of work. They analyze environments after cleanup to see whether or not it's clean enough. And yeah, if they cannot culture virus out of a select number of surfaces, and you know, they do it by percentages and statistics and so forth, then they can declare that a zone has been cleaned. So yeah, those things do exist.
Great. We have a comment from Michelle, who states, just in Brickell and the Miami Financial District, the number of residents and office buildings with more than 30 floors and more than 3 or 4, there's a number with more than 30 floors and more than 3 or 4 elevators. How can the community-based organizations prevent the spread? I imagine this is due to the close contact in some of these buildings.
Well, I will respond partly to this. One of our big concerns that we've already seen with nursing homes is how private management companies, whether it be commercial management companies or residential, are going to handle these types of buildings. That's an issue that has to be out there for discussion. Certainly, community-based organizations will be a big part of helping and looking for ways to do that. We hear that all the time. That's why they came to us to request the community impact rapid response model. But there's also going to be increased responsibility, accountability for the private managers, whether they be commercial or residential, of all the building types, the multifamily, the large office buildings and retail buildings. How are they going to be responsible when we begin to, well, even now where we have people living in these locations, but and working in offices, but as we go forward and begin any kind of a reopening, how does that play out? That's a really good question.
Thank you. And this one is for Michelle. Karina asks, where can people sign up for the Baptist Health newsletter? We can also add it in our email as a follow-up to all the participants.
Sure. I am sure that it is on our Baptist Health page under the community events. It's probably updated every single week. And if not, I'm happy to send it to her. If she wants to send me a message with her email, happy to forward.
Okay, great. And we'll also include it in our follow-up to all the participants. And one final question, can Dr. Marty speak to the FDA authorized first test for patient at-home sample collection?
Sure. So the U.S. gave an emergency use authorization for a product by LabCorp, and this product is called Pixel. And the way it works is it's not really an at-home test at all. What it is an at-home collection. So under a doctor's prescription, you would be sent a kit, just like if you've ever done like a DNA test for any of those companies. They would send you a little kit, and then you would use the swab. It's kind of like a Q-tip swab that comes in there, and you have to use their Q-tip swab because otherwise there might be genetic material on a Q-tip swab that you have in your home. So you have to use theirs, and then you would simply put it into saline the way you're supposed to for that, and then send it back to LabCorp. Is then authorized under this emergency use thing to do the RT-PCR test in their laboratory. So that's how it works. It's not really a test at home, it's a sample at home product.
Thank you so much. And with that, this concludes today's discussion. Thank you everyone for joining us today. As a reminder, we will be emailing participants a link to provide feedback for today's discussion, a link to today's recording of the webinar, and also sign up for next week's webinar. So thank you once more, and thank you so much to our panelists for joining us this morning.
Thank you.
Thank you. Bye-bye.